हेलो डॉक्टर चावला सर, आई सेंट इट टू यू, आप चेक कर लेंगे?
I think Chawla sir is muted.
Kiran, you have sent by mail?
सर व्हाट्सएप किया है, डॉक्टर चावला सर, आई सेंट इट टू यू, आप
क्या मैं डालता हूँ?
Sir is muted abhi. Sir, we can't hear you.
No, Nachiket, I was just inviting Dr. Rajiv to join.
Oh, right, sir. Thank you, sir. Thank you, sir.
Good evening, sir.
Good evening. How are you?
Good, sir. Good.
Sir, good evening, sir. Sood, sir.
Hello. How are you?
I'm well, sir. Thank you so much, sir.
Recovered fully?
Yes, absolutely fine, sir. Even mom has recovered, and but it does take a toll on you, sir. बहुत परेशान हो गए, and but by your blessings, सब ठीक है, sir.
बहुत बढ़िया.
वो तो आउट भी हो गया हैं? नहीं वो
आज फॉर्मेट क्या रखा है? आज फॉर्मेट क्या रखा है? There are students. Nachiket?
So it's on genito-urinary trauma, and I'll be actually. So it'll be an interactive come learn all, teach all session here, and with a few kafi, I've kept a lot of CT scans, all types of varieties of trauma, and I made an interactive presentation, so the residents would be interacting the whole time, and I hopefully will be doing justice to the presentation, sir.
That is fine. I only wanted that. How many residents? 2 or 4?
Sir, I think that 3 residents had to join, sir.
Okay. And who are they? Which are the institutions?
Sir, I wasn't given the details of the institution or the residents, sir.
Okay.
Yeah. Good evening, Dr. Rajiv.
Good evening. Good evening.
Yeah.
Is it time now? 8 o'clock.
Yeah. You can start, sir.
Yeah. Good evening, everyone. Chairman, Indian School of Urology, Professor Rajiv Sood. Co-chairman, Indian School of Urology, Dr. Arun Chawla. Faculty for today's program, Professor Nachiket, Vyas. Dear student friends, welcome to the next edition of the USI Resident Smart Learning Program. Today we have Professor Nachiket Vyas, Professor of Urology, SMS Medical College, Jaipur. He will be deliberating on various scenarios related to genito-urinary trauma. Again, this is again an important topic which all of you will be encountering in your practice, and how to face this scenario of genito-urinary trauma and what are the implications. So Professor Vyas will be highlighting on all these points. And with these few words, I welcome you all once again to this Resident Smart Learning Program. And I would also like to thank that the Lupin, Formica division of the Lupin has taken over the responsibility of all these Resident Smart Learning Program. This is an MIU between USI and Lupin. And thanks to the Formica division of Lupin for this educational initiative, supporting this educational initiative of USI ISU. With these few words, I would request Professor Rajiv Sood, Chairman of Indian School of Urology, to say a few words. Over to you, sir.
Thank you, Dr. Rajiv, and welcome Dr. Nachiket Vyas, professor and working in SMS Medical College, Jaipur. He is an eminent professor. The topic we are discussing today is genito-urinary trauma. And we know that in genito-urinary trauma, obviously in COVID, trauma has gone down, the incidence. And this COVID has given us, other than our this e-learning or distance learning or virtual classroom method of teaching, Urological Society of India has taken over this in a very efficient way. And for that, the USI Council and especially Dr. TP and Dr. Arun Chawla are to be congratulated. Now, this renal trauma or genito-urinary trauma, when we talk, it is 90% cases or 70% cases rather is renal trauma and 30% is in the lower tract. And the modalities have improved over that time. Now for decades, we are having CT scan in our armamentarium. And also this topic is important because the more of the genito-urinary trauma is in male, because the road traffic accidents are more in male, other blunt injuries are more in male, and urethral injuries become significant, and that becomes the very important part of our urology and urological surgeries and follow-up. And where we encounter all this is emergencies. So in the clinical practice, in day-to-day scenarios, hospital scenarios, road traffic accidents, trauma centers, you get referrals for that. And therefore, in the exam also, in the radiology, when in the table viva also, it is important. And it is important in almost every aspect of the question paper, theory paper, reconstructive surgery. Everywhere you will find some way or other way the renal trauma or the genito-urinary trauma getting incorporated in your day-to-day teaching and day-to-day practice, and also in the assessment and the examination when you clear your postdoctorate DNB or MCH. So therefore, with this important class today, which is going to be spearheaded by or interactive session, which has been designed by Dr. Nachiket Vyas, who is a master of the craft for such lectures, and he may be your examiner also anytime. So all the residents who are interacting, they are going to be directly benefited, and all your colleagues who have not yet logged in, they are to be informed that they should quickly log in to this virtual class. And I welcome Dr. Nachiket Vyas, and for that I hand over back to Dr. Rajiv TP to introduce him and invite him properly.
Thank you, sir, for your kind words. Now I would request Professor Nachiket Vyas, Professor of Urology at SMS Medical College, Jaipur, to take over the session for the further deliberations. Over to you, Nachiket.
Thank you so much, sir, for the kind words. I would also like to thank Dr. Professor Rajiv Sood, sir, and also Professor Arun Chawla, sir, for giving me this opportunity. Actually, they have also been my teachers, so it is actually an honor for me to be sitting over here in front of them. And I think that, as Dr. Sood has said, this is very important. And for the residents, this is because in some way or the other, they will have to have this kind of an interaction in their exam. and it's one very important part of their training also. If so, I think that they're going to benefit. I'd also like to again thank the USI for giving me this opportunity, and now I'll start my presentation. Do we have the residents? I'm going to share my screen now.
Nachiket.
Yes, sir.
Residents have decided to post the question on chat box, so you can continue with your presentation. Yeah.
Perfect, sir.
Yeah.
So I've just started my screen sharing, and I think that okay. So are my slides? Is my first slide visible?
Yes. Yes.
Can you hear me? Right. So I think that first of all, I'd like to tell the residents about the learning objectives. This is because now with the teaching that is happening across the country, I think that before any topic is taught to the residents or discussed with the residents, I think that we should discuss with them what ultimately is the take-home message and what are the objectives for them to understand. We know that this is a short case that they get inside the exams. So I hope that by the end of the presentation, you'll get to know these cardinal features about a small part of genito-urinary trauma. I was given 1.5 hours for genito-urinary trauma, but when we talk per se about genito-urinary trauma, then we have to start with the adrenal gland, the kidney, the ureter, the bladder, the urethra, which I don't think that was possible. So with your permission, I'll just be dealing today with maybe the kidney and with the ureter, and if later on I can be given an opportunity to deal with the other organs, that will be really nice. So I think that once this class is over, then the residents, they should know these key points about the classification, about the recent classification, about the AST classification, and also about the changes and why the changes in the AST classification was made. What is the present role of a single shot IVP? Is it still done inside different units, or is it still done inside the OT? And what is the protocol that is being used, and why is it still important? What are the different signs that you want to see when you're reading a CT scan? This is because now CT scan and contrast enhanced CT has now replaced all imaging modalities for a renal trauma case. And then once you're doing well, and once you've got over the part of the CT scan, then I think that how you are going to manage this patient, what incisions you are going to use, and how you're going to gain access to the major vessels. And ultimately, then if you are doing very good, and if you're able to tell about the complications and the causes of hypertension. So these are the learning objectives that we want to keep in mind, and we have to know while before going into the exam. So it is, as Professor Rajiv Sood was saying, in some way or the other, you are going to face something about renal trauma and ureteric trauma inside your exam. There is a possibility of a long question in theory, and definitely you would get a short case. And as Dr. Sood had said, that it is always a cardinal point to discuss renal trauma inside uroradiology. So I think that if you listen to the cardinal points that we are talking about, so you're going to definitely benefit from this talk. So this is a new teaching format that we have designed. So as we were talking about the learning objectives can only come when we teach along, when we learn along, and when we answer along. So the history of renal trauma case will always remain constant. That is why I don't think that you get a long case, you will only get a short case. So that is why I changed the format to teach along, learn along, and answer along. So now we're going to discuss today renal injuries. And after a few slides, I have a number of, if the residents would have been interacting, then it would have been nice, is because they'd been able to, look at the CT scans and tell what they see about the CT scans. If it's possible, then I think we can ask one of the, or two of the residents to unmute. So this is the most commonly injured genito-urinary organs, as Dr. Sood was saying. That majority of cases of genito-urinary trauma, the most common injured organ would be the kidney. And in 10% cases of all of the abdominal trauma cases, if that is taken, then the kidney is involved inside those trauma cases. And as we know that children are more susceptible in genito-urinary trauma, this is because understandably the children, they have got less of perinephric fat. The size of the kidney in relation to the body is slightly more inside children, and even they have got less muscles. So that's why children, they are more susceptible to renal injuries in the cases of trauma. And if there is congenital renal abnormalities, for example, like UPG obstruction, if there's a renal cyst, if there is an ectopic kidney, Usually the kidneys are protected, as we all know, by the ribs and by the vertebral column. If the ectopic kidneys are there, then these also increase the risk of having injuries inside genito-urinary trauma. So we know that the majority types of injuries, they can be blunt injuries and they can be penetrating injuries. But I think that one very big segment that still I was surprised that in many of the books it is not given as a separate entity now. I think that we have to keep even iatrogenic injuries in renal injury. This is because iatrogenic injuries, they can be produced by, as we do more and more percutaneous cases, for example, like PCNL or access to the pelvis and the ureter by endourological techniques. So this is a type of a controlled trauma. So besides blunt injuries and penetrating injuries, even iatrogenic injuries is a big segment that sometimes in our practice we have to deal with. It's because it is also a controlled trauma of the kidney. So renal trauma, as we know, is blunt. It can be on account of a road traffic accident. It can be on account of a fall or an assault, and then there can be penetrating injuries, as we know, gunshot and stab. Nothing new inside this slide, but we were talking about iatrogenic injuries. So this is a slide that I took from somewhere. It did not have iatrogenic injuries. So as I was just discussing, we should add iatrogenic injuries. This is because these are injuries that are managed. If they can be managed well, then we're able to save the kidney majority of times. And sooner or later inside practice, one has to come face to face with these kind of injuries which are iatrogenically created, be it the kidney, be it the ureter. So iatrogenic injuries also should be kept inside etiopathogenesis and also should be considered inside the causes of renal trauma. So we know that inside the evaluation, the reason that I didn't initially keep cases was that we were fortunate enough to conduct the USI mock examination, and inside a case of renal trauma, ultimately the history is always the same. Either the patient has an RTA, a renal traffic injury, the patient has a deceleration injury, the patient has a fall from height. So what I wanted to focus upon this new method of interaction with the residents was later on when they see the CT, then they can give the answers along what they are saying. So besides the different forms of blunt injury, deceleration injuries can also occur inside the kidney. We all know that deceleration injuries, they cause vascular damage to the kidneys, and these vascular damages, they can be in the form of renal artery thrombosis, renal vein disruption, which we do see many times, and also renal pedicle avulsion, which we do see, and also injuries to the UPJ. So how do deceleration injuries cause renal trauma? The renal trauma inside deceleration injuries basically is on account of the intimal injury. So what happens is that when the kidney, it's hanging by the pedicle and it's also attached with its attachments, but sometimes on account of deceleration, when there is injury and rupture of the intima, then it forms a nidus for a clot formation, and ultimately a thrombus will form. And unfortunately, these are those cases, if they are not detected early inside renal trauma, then we lose a number of units. And we do see these cases a few times, but however, they have to be managed very early. They have to be picked up very early. So this is the mechanism that he wanted. And unfortunately, it's one of those segments or it's one of those type of renal injuries that usually sometimes is very difficult to manage this because these patients don't turn up on time. So the clinical evaluation, I'm not going into the detail. We all know that the patient can have hematuria. He can have hypertension with hematuria, without hematuria. There can be flank hematoma. Sometimes the hematoma can be so obvious. In the presence of a lump, there can be a hematoma. There can be ecchymosis, and there can be a purple patch present at the flank. There's always abdominal tenderness inside the cases of renal injury, and the renal angle will also be full. And at that time, it's important to evaluate the thorax also. And inside our evaluation, we'd also see for fractures of the ribs, and also we have to look for any penetrating injuries inside the flank, or if there is any wound inside the thorax. So we all know that hematuria is a very important feature of renal. Yes, sir.
Nachiket, just sorry to interrupt you. Kiran is there?
Yes, sir.
Kiran, you can put Aditya 66 video on, mic on. He wants to discuss Dr. Nachiket's.
Okay, sir.
Then any other Vilala, I will inform you. Okay. Sorry for interruption. Okay.
So that will be absolutely. This is what I wanted. Actually, this is because just after this we're coming to the clinical scenarios, and there I would like to definitely discuss with the residents. So thank you very much
Yes.
for doing that. I really appreciate it. So we all know that hematuria is the cardinal feature of renal trauma, and hematuria, will ultimately decide what type of management the patient, requires, whether it is with shock or whether it is without shock. We all gone through the algorithms, and we all know the great work which was done inside the University of San Francisco by Dr. McAninch, which revolutionized ultimately the treatment of renal trauma, even for advanced cases. So I think that we have to see inside the first urinary allocae whether the patient has got hematuria. And it's surprising to see that inside pediatric patients, even if the patient has got a penetrating injury, then the hematuria is usually less. And inside blunt cases, the hematuria is usually more. Again, a study which was done by Dr. McAninch and his group. So hematuria, sometimes, even though it is an important feature, but many times you do not get hematuria, and we all know why we don't get hematuria inside the case of renal trauma. That is, inside renal pedicle injuries, inside type 4 injuries, inside type 5 injuries, when there is a total avulsion of the renal pedicle, or if there is renal artery occlusion. We were talking about the pathogenesis of renal artery occlusion, and inside 24% cases of renal artery occlusions, which is a total occlusion, we would not get hematuria. So that is why sometimes, even though it's very important to take a history of hematuria, the amount of hematuria, and what the nature of hematuria is, and whether it is associated with hypertension, but we have to remember that the severity of hematuria does not always correlate with the degree of severity of renal injury. And we've all seen inside a practice and inside a unit, pedicle avulsions and also renal artery thrombosis, which we have a few interesting CT scans which we are going to discuss later on. Hypertension, we all know, is one of the ominous signs inside the cases of renal trauma. And if the blood pressure is less than 90 millimeters of Hg at any given time, even inside blunt injury with macroscopic hematuria, if the systolic blood pressure is less than 90, then this is the cutoff which has been given inside the San Francisco paper, which so much weightage is given inside. And I think that the reason why 90 mm cutoff has been given, if you think of it, is because at around 80 millimeters of Hg, auto-regulation by the kidney stops. So I think that is the reason why Dr. McAninch has given a systolic blood pressure of 90 millimeters. The cutoff has been given, and if this is present, before resuscitation, then it signifies significant hemorrhage. So if you're able to know that renal autoregulation, it stops at 86 millimeters or sometimes around 80 millimeters. So I think that would be the reason why this cutoff was taken by the San Francisco people, and it hasn't changed inside all these years since I've been a resident. Still the cutoff, which is I think a cardinal cutoff, is 90 millimeters of Hg. So what are the indications of renal imaging? This is one of the questions, that is commonly asked inside your examination. What are the absolute indications of renal imaging? I mean, one of the early questions that you get if you're sitting for your uroradiology or your short case. So the answer that we want to hear is, number one, gross hematuria. We were just discussing gross hematuria. Hypertension with any degree of hematuria, that should always require a renal imaging. And based upon history, if the patient has got a deceleration injury, I'd also add one more thing: if the patient has got a fall from height also. And even in pediatric patients, with or without hematuria, all pediatric patients, even though inside the slide I've written hematuria, but even without hematuria, if pediatric patients are coming and if they have got a history of road traffic accident, then I think that you should undergo an imaging. This is because, as we all know, the sympathetic drive in children is much more that of adults. So that is why even if they are having a contained, bleeding from the kidney, they are able to compensate it with the adrenergic drive. So they might be having a severe degree of blood loss, which is contained inside the retroperitoneum, even without hematuria. So that's why this is because on account of the adrenergic drive that they have, which is much better than that of adults. So all pediatric patients, irrespective of whether they have hematuria or without hematuria, they warrant a renal imaging. And all penetrating injuries, irrespective again of whether they are inside the back, whether they're inside the front, but however, all penetrating injuries, they should be scanned. An imaging study should be done. This is because sometimes penetrating injuries also causing grade 3, grade 4 injuries to the kidney, sometimes hematuria would be absent. So that's why all penetrating injuries it is important for renal imaging, to be done inside these cases. So historically, renal imaging, these are all the imaging modalities that have been used. But we're not going to discuss all of them. This is because I just want to make a running remark upon ultrasonography, and that is inside your exams. The thing about ultrasonography is that as examiners, all of us are very fond of asking about FAST, F-A-S-T. That is a focus abdominal sonography for trauma. So the only question I think we were discussing about what your take-home message should be inside sonography. I don't think that you have to go inside the details. This is because it's obsolete investigations for renal trauma. Once CT scan has come, especially a single bed CT scan or spiral CT has come. So now we don't rely much upon sonography, but the only time a sonography is done is that initially if the patient has come to you inside your emergency ward and you have to do a focus abdominal assessment, then a FAST can be done. Otherwise, even a color Doppler does not have much of a role these days inside deciding what type of management you want to give your patient. So I think that the spiral CT will be discussing in detail later on. IVU, a lot of emphasis was given before when IVU was freely available, and CT scans weren't available even inside B grade towns when CT was not available. This is maybe around 20 years back. IVU, again, it has gone into oblivion, but however there is still a role of a single shot IVU, which we'll be discussing inside the subsequent slides. MRI, if you have an MRI, then people sometimes they will replace the spiral CT with an MRI. There are equal number of papers that say that MRI is better. This is because the soft tissue resolution of an MRI is better. Then you do not need much of a contrast inside MRI, whereas inside a CT scan, it's always better to do it with a contrast. Angiography has got very limited indications, and we were talking about the iatrogenic traumas to the kidney. Iatrogenic trauma, especially after post-PCNL trauma, if you have bleeding inside those cases, we'll be doing an angiography. Otherwise, routine angiography is not done. So the take home message from this slide is that ultrasonography, only you do it for FAST. Spiral CT is the backbone of grading and staging renal traumas. IVU only inside the OT. I mean, if you did not have a time to do a CT scan, then still it has got a very limited role. All examiners are fond of asking about the single shot 10-minute film, so you should know about IVU. MRI angiography, not that much. Sorry, I think that my slides are hanging. Can you hear me?
Yes, we can hear you.
I'm having little trouble. I think that my slides are.
There is an arrow on the bottom. Yeah, contrast and CT has come.
Okay. So now contrast. Thank you, sir. So inside contrast enhanced CT, we were discussing, and as I was telling you, that is a single best modality for grading renal injuries. And nowadays it is rapid. It does not take the same time that it used to do. Now with spiral CTs and with helical CTs, even inside a single breath span, or even inside less than maybe 2 minutes, you can get a very good quality of a CT scan for the abdomen and the KUB region. And it also gives you 3-dimensional data. Reconstruction can be done upon the console at that time. And it gives also functional data, because we are giving contrast. So we get to know a certain, with some certain degree of certainty about the functional data or the function of the kidney. And it also helps us inside evaluation of concomitant injuries, for example, we all know. So we'll also know about the other injuries that the patient is suffering from. So this is the investigation of choice. And so what you're looking inside a CT KUB, the ominous signs inside the CT KUB, all of us know about the lacerations that can be grade 1 lacerations, grade 2 lacerations, grade 3 lacerations, grade 1 injuries. But the important or the ominous signs inside the CT are, number one, a medial hematoma. If there is a medial hematoma, it would requires with a lot of suspicion that there might be some vascular injury. And also sometimes, you have to then tailor your CT. Maybe the patient requires frequent CTs, especially if there is extravasation inside the hematoma, and also, if there is an expanding hematoma, or the patient, hemodynamically becomes unstable when he's inside your treatment. So the most important thing that you want to see is that you have to focus also upon what's happening inside the middle part of the the kidney, and because that is the area where your most dangerous organs, or the most danger lies. So this is the grading of the renal injuries. This grading system has been changed. I have, for some purpose, kept the old grading system. This is because then in my subsequent 2 other slides, I wanted to tell what the changes inside the grading system have been. So I'm not, reading every line. We all know, and we all know what it is. We've seen inside the mock exams inside a department. So over here, it can be a contusion grade 1 or a hematoma. This is a subcapsular or all. And over here, the parenchyma is involved up till grade 3. So there is no involvement of the pelvic leishal system. That is the 2011 AAST system. So inside grade 4, we have involvement of, the collecting system. And there you have the problem starts in grade 4 when, extravasation starts, and you also have a major laceration, which is involving the renal artery or the vein. But however, this has been changed now. We are just discussing the changes. And then grade 5, we have a laceration, which is a completely shattered kidney, and a vascular injury, which is an avulsion or devascularized kidney. So now, what are the modifications? Inside 2011, changes were done inside grade 4 and in grade 5. So in grade 4, we were discussing that the involvement of the laceration to the collecting system, and also in the involvement of the main renal artery or the renal vein, these are inside the grade 4 injuries. But however, the revision has been that any segmental artery or vein, if there is thrombosis or involvement of the segmental artery or the vein, then this becomes a grade 4 lesion. And at the same time now, shattered kidney, which we used to consider as a grade 5, now if the patient comes with a shattered kidney, then that is considered to be a grade 4. So these are the important changes that you need. This is because inside the exam now, these changes have started to be, people have started to ask about what are the changes inside the grading system. And what is the change that is made in grade 5? The grade 5 change is that now only vascular injuries are considered to be the grade 5 injuries. That is, there can be arterial injuries, there can be venous injuries, there can be laceration to the arteries, there can be avulsion or thrombosis of the arteries. So this is the changes that have been done. I've just covered them, and the changes have been done inside grade 4 and grade 5. So now I'm just showing 4 CT scans, and then we have around 13 CT scans which I'd like the residents to comment upon. So I've already given the diagnosis inside these CT scans. So this is the first CT which has shown a grade 1 renal injury. We can see a well-defined subcapsular hematoma that is confined to the subcapsular area, and it is crescentic. And depending upon the Hounsfield units, we get to know whether it is a recent hemorrhage or whether it is a old hemorrhage. So we can see that the function of the kidney is well maintained. We can see contrast also inside the pelvic leishal system. The cortical enhancement is perfect. So this is the hematoma that you see. This is known as a crescent sign. Some people call it the halo sign also, but calling it a halo sign is very controversial. This is because some people do not consider it to be halo sign. They want to keep the halo sign for acute infective collections that you get inside infections like pyelonephritis and pyelonephrosis. But some people call it the halo sign, but it looks like more of a crescent. So this is the next CT, which you can see is a grade 3 injury. The grade 3 injury inside, it's being conspicuous by the arrow. It is going very close to the pelvic leishal system, but however, there is no rupture or involvement of the pelvic leishal system. You can see the calluses and also a little bit of dye inside the pelvis. So this is the laceration. You can see it's a fairly large laceration, and there's also some collection. I'm sorry about the quality of the CT scan, but once you have to enlarge it in size, and it becomes a little grainer. So this is a grade 3 injury. Now, this is a grade 4 injury where you can appreciate that the contrast has extravasated inside the perirenal space. Now, a common question that residents commonly ask is that how do you know whether it is contrast which is, whether it is blood or whether it is contrast which is a see. If this kind of an extravasation is seen only early, that is when the cortical when the cortex of the kidney or inside the nephrographic phase is there. If you see this kind of a thing, then it is definitely blood. That means the blood has come from some source. Either it has come from the artery, it has come from the segmental artery. That is, if you see it inside the nephrographic phase. And the nephrographic phase, we all know it is within, a few seconds, 20 seconds to 40 seconds, we get enhancement of the cortex. And if you have this kind of a picture inside the very early time a CT scan is done, then it shows that most likely it is blood. But over here, if you take a delayed film, and inside delayed film on CT, we mean if you take it after 2 minutes, if you take it after 3 minutes, then if you see this kind of a picture, then we have ossification of the pelvic glacial system, and most likely this is dye which has come from the pelvic glacial system. So this is one method in which you identify whether it is blood which is going into the perirenal space, or whether it is contrast which is going into the perirenal space. This is one way. But for that, you have to ask your radiologist to tailor the CT scan. This is because these days, as we were discussing with the spiral or with the helical CT, everything is completed within 1.5 to 2 minutes. If you want to see for the pelvic glacial system, if you want to see dye inside the ureters, if you want to see dye inside the pelvis, then you have to ask him to take a little bit of delayed film. So this is a grade 4 injuries, which is showing extravasation of contrast inside, the pararenal space. This again is a CT scan of the kidney which was done. And you can appreciate, always start from the normal kidney. It's very pertinent to see the normal kidney inside the CT scan. If you look at the right side, then the right side, we have a wonderful cortical phase, we have a nephrographic phase, then we have dye inside the pelvic glacial system also. So this is most likely, a delayed film which has been taken, and the opposite kidney is absolutely black. We can see the pelvic glacial system over here. We can see the cortex, the capsule of the kidney. There's no enhancement. So that means most likely the patient, either there is an avulsion of the pedicle, or the patient has got a renal artery thrombosis. This patient ultimately, was identified to have a renal artery thrombosis, and a renal artery thrombosis diagnosis is made once you get a black kidney on a CT scan. This is now. Can we have sir, the residents, if they want to? We have around 10 CT scans, which I would request the resident to read if they can read. Aditya?
Yes, sir.
So,
yes, sir.
So the aim was, Aditya, was to show you the CT scans, to show you the different grades of injury. Now we have around 9 CT scans. This is because this is definitely going to come inside your exam. So this is considered. Just think that this is your radio, uroradiology is going on. So what is your comments about this CT scan, Aditya?
So in this CT scan, I can see the left kidney. The right kidney is not seen, and there is it seems to be either a nephrogenic phase, but the dye, as in the heart, it might be a segmental injury to the kidney, because
yes.
Segmental injury might be there, sir. And because of this, half of the kidney, as in the anterior half of the kidney, is the uptake is good, whereas the posterior half, the uptake is not there.
So what is your
grade
diagnosis?
4, grade 4 renal injury, sir.
Okay, Aditya. So you're saying that it's it's a segmental arterial involvement, and you think that this part of the kidney has got involved on account of arterial injury. And can this be a contusion of the kidney also? If there was an arterial involvement, we were talking about extravasation of blood, and we were talking about extravasation of contrast. Do you think that if it would have been such a big arterial,
venous, can it be can it be venous also? Because arterial, I cannot see the aorta, the contrast I cannot see anywhere. So it might be. I'll more go towards the venous injury, segmental venous injury. But
so do you think, Aditya, that you're able to visualize segmental veins upon maybe an axial cut of this amount? Do you think that the veins are visible?
No.
Okay. So I think that I'll give you one thing, that first of all, you saw that it is a case of a solitary kidney. We cannot see the opposite kidney. One kidney is totally absent. And you absolutely made a correct assumption that half of the kidney, it seems to be, it is not enhancing. So what could be the causes of non-enhancement? So what is happening, Aditya, is that you cannot see the dye inside the renal artery also. So you cannot make assessment of a segmental injury. Otherwise, as we were discussing, which is very important, as I told you, that residents always ask whether it is, dye that is extravasating or whether it is blood that is extravasating. Still, you cannot see any of the the arterial structures. See, you cannot see the renal artery, you cannot see the renal artery of the opposite side. Maybe you cannot see the enhancement of the pancreas. So it might be that this CT scan has been taken at a very early phase. So that has just been taken immediately, just a few seconds, maybe less than 10 seconds, maybe less than 20 seconds. So actually, this is a case of a renal contusion. Right. So you can see a contusion, which is going, it is not an arterial injury, but you can see the contusion, as you rightly said, that there is no enhancement or there is very little enhancement. And this contusion of the kidney of the kidney is just, confined to the kidney. So it's a grade 1 injury. So it is not an arterial injury, but however, it is a segment injury. But I would definitely applaud you that you saw immediately that is a solitary, kidney. So that was very good. So this is a grade 1 injury. So here is another CT scan. So what is your inference? This is a sagittal cut that we have made.
Okay. So is this this is another patient, right, sir?
Yes, this is another patient. And as you see, what do you think about the age of the patient? What can you see? It's a case of renal trauma only. What are the positive findings that you see inside this CT scan, Aditya?
Yes, sir. So, sir, again, in this patient, I am not able to visualize the right kidney.
Yes.
The age, I suppose, because of the aortic calcifications, I'll say he's an elderly gentleman.
Yes, yes. So one thing that you're absolutely correct is that you can see atheromatous plaques inside the whole of the aorta. So this gentleman was a 65-year-old obese male, and he was, I'll also give you some history. Aditya, he was diabetic also, and he had a renal trauma. He had a road traffic accident and he came with hematuria.
Okay, sir.
He's insulin dependent, and he's a type 1 insulin dependent diabetic, 65-year-old. He had a renal trauma with hematuria.
Okay, sir. Sir, this is a delayed phase where the contrast is appearing in the pelvic ileal system.
Yes.
In the pelvic ileal system, now I cannot see any extravasation of the contrast.
Yes.
But in the pelvic ileal system, there is near the pew junction, there is one radio opacity. So
no, I'd call it hypodense because it's a CT scan. Don't call it a radio density. You're not sure. It's a hypodense lesion which is present in the pelvis, or you can even call it as a filling defect.
Filling defect, yes. So it can be. It is a filling defect. So with the history, it can be a clot also, sir.
It can be a clot, yes.
And I cannot see any extravasation of the dye. Moreover,
yes,
obviously,
you've already told us that you can see. Yes, you cannot see the ureter also, but it doesn't seem to be, that the distal ureter might be because it seems to be a case of a solitary kidney and there's so much of urine in the bladder, right? So, most likely there would not be any ureteric injury, right? Can you see the partially filled bladder?
Yes, sir. I can see the.
Would you like to tell me something specific about the pelvic ileal system, Aditya? This is because, as I told you, that the patient is a diabetic patient.
There is medially, I think there is a collection there. I'm on the medial side.
Okay,
but yes, sir. That.
Where my arrow is, this is a collection?
Yes, sir.
No, it doesn't seem to be a collection. It seems to be totally separate from the kidney, Madhurina. Maybe this is just some soft tissue. There is no collection. Okay, let me give you a hint, Aditya. Can you see all the calyces of the kidney? The patient is a diabetic, type 1 diabetic.
No, sir. As in, all the calyces are not very clearly visible.
What calyx can you not see, Aditya? He is a diabetic patient.
Upper calyx.
You cannot see the upper calyx.
Okay, yes, sir. Okay, yes, sir. So
you can see the middle calyx. You can also see the anterior middle calyx over here.
Yes.
You can see the lower calyx also, but Aditya, you cannot see the middle calyx in this patient. This patient is a diabetic and he has also got a filling defect. It might be a hematoma. He has a history of trauma. He has hematuria. So what do you think that this can be?
It can be a clot also. It can be papillary necrosis also, sir.
Very, very nice. It can be a clot. It can be papillary necrosis also. This because we know that in diabetics but the patient is having hematuria. Do you think that in papillary necrosis the patient can have hematuria?
No, sir. But superimposed trauma is also
Aditya,
there, no? Right?
Aditya, sometimes in papillary necrosis, you do get hematuria. This is because we all know that the papilla, they are, relatively vascular structures. So Aditya, if the patient has got papillary necrosis, sometimes they present with hematuria, very rarely.
Okay, sir. Sir, history of trauma was there, right?
Yes, there was a history of trauma. He came with hematuria.
Yes. Okay.
Two things that I want to, after giving a little bit of hint, you were absolutely correct that you cannot see the upper calyx. Now we have other CT scans to discuss. So I'll tell you that he had a filling defect inside the renal pelvis, and he also had hematuria. He has a solitary kidney. So now this is one of those, cases in which, if you're giving your exam, then your examination can go anywhere. So we know that it can be a papillary necrosis. You cannot see the upper calyx. So Aditya, can you tell me what are the causes of papillary necrosis? A renal trauma is such a diversified, topic that, you can go anywhere with renal trauma. So can you tell me the causes of papillary necrosis?
One is diabetes, sir.
Yes, diabetes तो हो ही गया उसमें और
pyelonephritis.
Yes, pyelonephritis and infections of the kidney, even pyelonephrosis is a common cause. And
because the patient is
this is a very commonly asked question. What are the causes of papillary necrosis?
Yes, this analgesic abuse.
Yes, analgesic abuse. And do you know any other abuse that can result in papillary necrosis, Aditya?
Ketamine abuse?
No. Ketamine does not affect the kidneys. It causes ketamine cystitis. Aditya, alcohol intake, chronic alcohol intake and chronic alcoholism can also result in papillary necrosis. So Aditya, there is a mnemonic, and we're very fond of asking this mnemonic inside the exams. All examiners know this mnemonic, and this mnemonic goes by the name of postcards. So postcards, these are the causes of papillary necrosis. P is for pyelonephritis. O is for obstruction. Especially if you see a case of xanthromatous pyelonephritis, you can get this. Sickle cell anemia, S for sickle cell anemia, T for tuberculosis, and a C for chronic liver diseases. Chronic liver diseases and other chronic diseases can also result in papillary necrosis. As you said, A, analgesic nephropathy can also cause, even alcohol ingestion. R is for renal transplant patients. Sometimes renal transplant, surprisingly, they have got papillary necrosis. This is because what happens is that the papilla area becomes anoxic if the kidneys are not well vascularized. And once anoxia and hypoxia sets in, then what happens is the papilla gets necrosed. So renal transplant patients can also, in diabetes and systemic vasculitis. So remember for your exams that this can be asked. So this patient, has a filling defect. Why it can't be a TCC, Aditya?
Because, sir, this is a little bit of enhancement should be there. Also, the patient was having hematuria post-traumatic.
Yes, so ultimately, let me cut short because we have many CT scans to see. Then we did a diagnostic ureteroscopy in this patient, and this patient was diagnosed just to have a simple blood clot. The message that I want to give is that always read about papillary necrosis. Diabetics is just don't get fixated upon trauma. And this is a trivial trauma that he had, and he had just a small hematoma in the pelvis which was removed, and the patient was conservatively managed. He has a solitary kidney, so his creatinine initially shot up, but this is one of our patients at our department, right?
Yes.
So now we're coming to the next. Would you like to comment on this, Aditya? Is a case of renal trauma, road traffic accident.
Yes, sir. Sure. Okay, sir. So even in this CT, I can the right kidney is visualized, the left kidney is not visualized. There is
yes.
There is medial, there is perinephric fest standing on the right side.
Yes.
And there is medial collection is there.
Has the cut been taken in the early phase or inside the late phase? Can you comment about that?
The early phase.
Yes, very early phase.
Very early.
This was as minimum enhancement of the contrast. Anything else you told about perinephric stranding, and most likely there is a subcapsular hematoma also. Anything else, Aditya?
And sir, on the anteromedial aspect, the uptake is less.
Okay.
So I'd like to see further phases in this film.
Anything else? Aditya Mother, there's such a big arrow. Sometimes we give you arrows and maybe you would want to comment this. There must be something inside the arrow, you know. Can you see this arrow inside the center, dead center?
Yes, sir, I can see the arrow. But
So do you think that the arrow is pointing to someone, something?
Sir, I cannot. I won't comment only on this.
Can you see the aorta and the IVC?
Yes, sir.
Okay, can you tell me something about the aorta and the IVC?
Sir, it can be a renal artery injury.
Okay.
But again, there's a collection between the aorta and the IVC. The IVC seems to be a little bit pushed ahead. However,
this is what we want to hear. This is what we want to hear. It's not pushed little ahead. Aditya, it's going to Tamil Nadu. So you see, it's so okay. It's so farther. You know, there's a large hematoma, retroperitoneal hematoma, which is being, it's just crying to be told. With the arrow has also been put over here. So it's a large hematoma, which is retrocaval. It is also anti-aortocaval. It is also going anterior to the aorta, and the whole of the IVC has been pushed anteriorly. So this is what we wanted to hear. And as far as the kidney goes, there is also, a contusion inside the kidney, which is anteromedial, as you said, more medial. So now you have a contusion of the kidney, which is medial. You have a large hematoma, which is pushing the IVC. The first thing that should be obvious inside this CT scan is that where is my IVC going? IVC should be over here. Can you see my small arrow here?
Yes.
Now the IVC, instead of here, it has been pushed over here. So this is a case in which there's a large hematoma. And even though the majority of the parenchyma of the kidney seems to be spared, but on account of medial hematoma, then we have to be very careful inside the treatment and the evaluation of this patient, right, Aditya?
Yes.
So you cannot miss these arrows. Sometimes, we do not remove these arrows, and we want you to, you can say about this, there's a solitary kidney, I can see this, but this is what we want to see. And you have to be careful this, because ultimately if you plan to operate this case, then the IVC would be distorted. So this is what we want to hear as examiners, right?
Okay.
So this is what you have both the kidneys. There seems to be pathology in both the kidneys as a patient who had a fall from height. So what do you see, Aditya?
So both the kidneys are visualized.
Yes.
This appears to be a nephrogenic phase. And in both the kidneys,
yes,
on the posterior aspect, there appears
yes,
to be a contusion.
Yes.
And there's also on the right side, there's perinephric fat collection, perinephric strandings are there.
Yes.
On the right side also, towards the medial aspect, there appears to be some more collection.
Yes.
Both the vessels are seen in their proper position.
Yes. Aditya, where can you see the vessels? Can you see the vessels? Can you trace the renal artery? I think that you're doing very well, but one of the important thing as a student also is that don't overread the CTs also, because I don't think that any vessel can be seen. You cannot see the renal vein, you cannot see the renal artery. So sometimes overreading vessel also.
Only. Okay.
Yes,
okay.
You cannot see the renal arteries, so just say that you cannot see the renal arteries.
I cannot see the renal vessels, just the aorta.
Yes. Yes. So Aditya, you read this CT scan absolutely correctly. So you see the pathology is bilateral over here. The aorta and the IVC and the aorta, they seem to be normal position. There seems to be a little bit of collection over here. You also mentioned about the perinephric collection, which seems to be a subcapsular hematoma. Then you said that there seems to be 2 contusions over here. Now my question, Aditya, if you give this answer, then you're absolutely pass. Nobody is going to, give you less marks. You're going to get very high marks. But can you tell me the difference in between the contusions of this kidney and the contusions inside this kidney?
So the contusions on the left side are extending almost up to the pelvic ileal system.
Okay.
So
which is larger and which is smaller? Which is larger and which is smaller?
Left side one is larger.
Okay. And is there any difference inside the shape of the contusions? Is there any difference in the shape?
It might be this segmental vessel injury.
Perfect, Aditya. Now you've got it. Actually, it was a segmental injury on this side, and you can see one. This is more in the shape of a wedge shaped. It is also known as the pizza slice appearance. Some people call it as the pizza slice appearance because it is exactly like a pizza that you get. the center would be conical over here and the base would be large. This is a true contusion, of the kidney, Madhajan, a large contusion posteriorly. And this is a segmental injury which is causing, an infarction of this segment. It is a pizza slice appearance. And this, Aditya, is also known as a renal sweat sign. This is the renal sweat sign that you can get in pyelonephritis. And can you see a little bit of fluid collection? Maybe the capsule is visible over here.
Yes.
So, this is the renal sweat sign that you were telling. So no marks are going to be detected if you've given the answer like this. But Aditya, this is, a wedge infarction, and this is a contusion of the kidney. And so that is why I wanted to put up this, CT scan, even though it seems like a contusion, but however, this is exactly like a pizza slice. So you were, I think that you got 90% of the things correctly, and I congratulate you for that. Now, I'm sorry, I'm again having, problems with my, changing my slides. I think that maybe, my computer got hanged or something, Okay, so can someone else change the slides? Nahi, wo nahi ho payega na. Someone else change the slides. I'm sorry, my computer has got hanged up for some reason. Okay, so Aditya, now I'm sorry for the delay. Now this is another CT scan. Can you read the CT scan, Aditya?
Yes, sir. Sir,
Again, as I told you, the history will not change. Again, it's a renal trauma with hematuria.
Okay. So, sir, in this, both the kidneys are visualized. This also appears to be a nephrogenic phase of the CT scan. The right kidney appears to be normal. In the left kidney, towards the posterior aspect, there appears to be laceration, and there's also collection. And
there's also a collection. There is a perinephric collection also, and there is a laceration. So how would you describe this laceration over here? This laceration is going from this aspect of the kidney, and it is going to the hilum of the kidney. So this can be described as a fracture of the kidney. Can you call it as a fracture?
Yes, sir.
So this is basically a grade 4 type of multiple fractured kidney. So now my question goes to you, Aditya. What is a pseudo fracture of the kidney? One of the differential diagnoses of renal trauma is a fracture of the kidney, and then we have a pseudo fracture. So what is a pseudo fracture? Have you heard the term?
No, sir, I've not heard.
So let me tell you what a pseudo fracture is. So what happens is that when patients who have previously undergone renal surgery, especially endourology, when we used to make a tract, then the size of the tract that used to be used was 30 French, 32 French, right? So that is a controlled trauma in a PCNL. So that is going to the pelvic glacial system, right? So when that tract heals, then when that tract heals, then what happens is that it becomes, it does not enhance. And sometimes you can have confusion that maybe it is a fracture or isn't it a fracture. So sometimes if you see a patient, if you do a CT scan of a patient who has got a healed PCNL tract, then you will have a linear tract. That tract will be going to the pelvic glacial system. It will be going medially. There will be no enhancement or minimal enhancement, and that would exactly look like a fracture of the kidney. So that is known as a pseudo fracture.
Yes.
So you have to, it's very important to know the history of a patient. This is because sometimes a pseudo fracture of the kidney can be reported in a patient of trauma as having a fracture. So it's important to know the previous history, which we do inside our trauma patients. The other cause of a pseudo fracture, sometimes what happens is that when a cut is taken, this is because we're doing a CT scan, and these CT scans, they are taking cuts. Sometimes when the cut goes inside a large indented hilum, then sometimes this indented hilum, this is because you are taking an axial cut, which is not a 90-degree cut. Then this indented hilum is visible inside one of the poles of the kidney. Then that is also being described as a pseudo fracture. Did you get my point?
No, sir, not this second point I did not get, sir.
You did not get the second point. Okay, so we know that a CT is an axial cut. It is known as a CAT scan, a computerized axial tomography. So these axial tomographies, Aditya, they are not at 90 degrees, but however, they are at a certain angle. Sometimes when the CT is being done, and if their patient has got a hilum, which is a deep-seated hilum, and if the can you see the movement of my arrow?
Yes, yes, sir.
If the cut is taken like this, and there is a deep
Yes.
hilum, sometimes you have patients who have got very deep hilums, then sometimes that hilum image goes inside the cut of the kidney, which is very similar looking, just like a fracture of the kidney. So that is also known as a pseudo fracture, right?
Okay. Yes, yes.
So you were correct inside saying that this is multiple fractures you can see inside the kidney, but you should have also mentioned that there was a little bit of that seemed to be a hematoma, and it's because the dye has not come inside the pelvic leachal system, but it's come medially. So maybe there can be some collection
I'll wait
over
for
here.
the delayed
So
phase. Yes.
No. Yes. You need not, Aditya, you need not wait for the delayed phase. This is because this is acute hemorrhage. It must have been accumulated at the time that the CT was done. So this was white blood. Acute hemorrhage sometimes can be seen like that, right?
Okay.
Yes. Aditya, can you comment about
yes, sir.
This? Yes.
So this appears to be a nephrogenic phase. Both the kidneys are visualized.
Yes.
In the right, on the right side, there appears to be a collection, particularly on the medial aspect. There appears to be there appears to be on the medial aspect fracturing of the kidney. The renal.
Yes, I think that you're getting my point now, which was very important. You said that there seems to be some extravasation. Do you think that this is arterial? Do you think that this is blood, or do you think that this is dye?
So the arrow which you are showing, that
black arrow.
I think black. So this should be blood.
Yes, exactly. I'm now very happy. I think that you got the point about how to differentiate between blood and how to differentiate between contrast in the pelvic lesion. This is blood which is present. There's a medial hematoma, so most likely this patient has got a grade 4 or a grade 5 injury, and anything else you'd like to comment about? There is a medial laceration also, and there is extravasation from the artery over here. So this is in the arterial phase, and still we cannot see the pelvic lesion system, but most likely it's a grade 5 injury. This is because grade 5 injuries, now they are vascular injuries. Anything else that you'd like to comment upon the CT scan?
So the white, now the is the on the back the white arrows. Now they are.
Yes, what are the white arrows showing?
Is there subcutaneous emphysemas?
So the white arrows are showing something black. So it has to be air.
Subcutaneous emphysema, I guess.
Okay, subcutaneous emphysema can be black, definitely on a CT scan. Can you see anything else inside the CT? Just look around the whole of the CT. Anything else? Can you see my arrow, Aditya? I'm moving my arrow. Can you see my arrow?
Yes, sir. Yes,
okay,
sir.
So can you follow my arrow? What is this, Aditya?
Yes, I cannot see your arrow.
Can you see my arrow now?
Yes, sir.
Can you follow my arrow? What is this, Aditya?
No, sir, I cannot see your arrow. Yes. Now I can see your arrow. Oh, okay, sir. Actually, I was not able to see the. Yes. Okay.
Okay, can you see my arrow? What is this?
Yes.
So this was a gunshot injury.
Yes. This is a bullet, sir. Bullet. Gun. Yes.
Yes. So this is a patient who had a gunshot injury. You can see the whole tract which is going subcutaneously, and we've not even removed it. It's just at the level of the skin. So now you can see ricochet also, and these are air pockets from another tract of another bullet. So this patient had a penetrating injury. Penetrating injury caused more devastation. So it was a grade 5 injury. The metallic object is still over there subcutaneously, and these two which you are saying as subcutaneous emphysema. Absolutely correct. They are air pockets, and they are from the tract of the of the bullet, right?
Yes.
So you answered very well. Congratulations. What is this? A spot diagnosis. We've already talked about it inside the CT scans that I was telling.
So this is a renal artery thrombosis.
So this is a renal artery thrombus. You can see an absolute
Thrombosis.
black kidney. I also showed a previously
Yes.
CT scan. Opposite kidney is absolutely normal. So Aditya,
Normal.
how does a patient of renal artery thrombosis present as? What are the cardinal features of renal artery thrombosis?
So after trauma, there will be flank pain,
Yes.
hematuria.
Yes.
Then later on, there will be hypertension.
Aditya, there will be
Then,
immediate hypertension. It's not later on. There
immediate
is massive
hypertension.
hypertension. One of the causes of malignant hypertension is such an artery stenosis. So you are correct. It won't be later on, Aditya. It will be immediate. This will be a renin-induced hypertension, and the patient will have malignant hypertension. As you said, the second feature would be hematuria, and the patient can have flank pain also. So what is the difference in the presentation of a renal artery thrombosis and a renal vein thrombosis? Can the patient of renal trauma also have vein thrombosis?
Yes, sir, he can have.
Can I just show you another?
Renal vein
Can I show
thrombosis
you another?
Yes, okay.
Okay, so we'll do these two CT scans together. Aditya, can you tell me anything that you see inside this? What is this?
Okay, sir. So in this, both of the kidneys are visualized.
Yes.
Mostly this is a delayed phase because I can see the dye in the pelvic ileal system on the right side.
Yes.
However, on the left side, I cannot see a dye. But what the arrows are pointing, the vein appears to be dilated and there appears to be a thrombus inside.
Yes, there's a filling defect, and the arrows, they were just screaming out to mention a filling defect, as you correctly did, and you were correct that there's a filling defect inside the vein. So you can see the cardinal features of renal vein thrombosis, Aditya. Number one, there is a filling defect, as you can see. Number two, this filling defect, there is abrupt change inside the lumen of the vein. Can you see the end of the vein? Can you see the end of the vein here?
Yes, sir.
So you can see the whole of the vein is dilated over here, and then there is a sudden change in the caliber of the vein.
Yes, sir.
Right, and if another cut is taken, then maybe you'll be able to see the IVC. The IVC inside this cut is not seen. So number one, dilatation of the renal vein. Number two, a filling defect inside the renal vein. Number three, enhancement of the kidney. This is because that is the difference in between. Let me go back one slide. See, inside a renal artery thrombosis, there will be a totally black kidney, and inside renal vein, there will be, enhancement of the kidney. Right? There can also be some, tethering which is present. There can also be some fluid connection inside renal vein thrombosis again, which we have some fluid collection over here, and there can be a sudden cutoff. So this is a feature of renal vein, as you said, thrombosis. So what are the clinical features of renal vein thrombosis? Renal artery thrombosis, you said there will be pain, there will be hematuria, and there will be hypertension. So renal vein, how would you clinch the diagnosis clinically?
So here also, sir, there will be pain and there will be hematuria. I'll say hypertension will also be there.
No, that will be inside so many things. Inside even arteries thrombosis, you can have the same thing. What is the difference in between renal artery thrombosis and renal vein thrombosis? Hematuria is there in both. Pain is there in both.
There will be, if it is on the left side, then there will be the dilatation of this.
No, I don't think there'll be any difference clinically on the right and left side. Can you see one of the demarking features and the difference of both is proteinuria. There will be massive proteinuria and renal vein thrombosis.
Okay.
You do not get proteinuria inside an arterial thrombosis, but if you do a urine examination inside these patients, then you will give massive proteinuria inside renal vein thrombosis, right? And as you clinically, as you rightly said, this is a vein, there's a filling defect inside the vein, and you can see the change in caliber and all the features that we discussed, right, Aditya?
Yes, sir.
Now, Aditya, what is this?
So this appears to be an arteriogenic phase. Only the left side is visualized. There's on the posterolateral aspect on the left side.
Actually, the only right side is visualized. This is because, we just took half of the CT so that the finer details could be shown.
Okay. So there is a collection on the posterolateral aspect, and there is And is this post? Sir, there are gas shadows also. So sir, trauma. When did the trauma happen in the patient? Sir, any history? Is it just post-traumatic?
Yes, the patient, it's a road traffic accident, and the patient presented with hematuria and also, and he had tenderness on the flank, and he also had a lump in the flank.
Okay, so there's this is a massive retroperitoneal hemorrhage which has shifted the kidney more anteriorly. So
it's retroperitoneal hematoma. So it's a
yes,
retroperitoneal hematoma. Very good. Yes.
Retroperitoneal hematoma.
Yes, absolutely correct. And
so in the kidney also there is a laceration is there on the posterolateral aspect. I think it is extending up to the pelvic ileal system. So this should be urinoma, and because it is a nephrogenic phase, and I can see blood also, so it might be blood.
Aditya, if you call this a urinoma, then please don't mind me saying that this is going to be a big blunder, buddy. This is because a urinoma will be absolutely, will not have these Hounsfield units. You can see enhancement Hounsfield units, white structures, this active blood, inside this hematoma. So once you said hematoma, which was absolutely right, there's no urinoma.
Okay, so okay, sir, because the shape was so used, so I thought it was mixed urine plus blood, because there are white structures also. It is a nephrogenic phase also. So that is why
it's blood. Actually, it was blood. Hounsfield units that we took were about 65, 70. So it showed blood collection inside the retroperitoneal hematoma.
Okay, sir.
Anything else you'd like to add? So Aditya, this was basically an exophytic angiomyolipoma. The thing that we were, looking for is that you're going to tell us that, okay, there is a solid, you have, a mature fat content inside the whole of the kidney. This patient came to us. He was a known case of a very large exophytic and, angiomyolipoma, which is having a retroperitoneal bleed. And this retroperitoneal bleed occurred after trivial trauma. So Aditya, what is the name of the syndrome? Now it's really simple. You have to see at the fat. Yes, it's a classical case of Wunderlich syndrome, which has pushed the kidney anteriorly. And this is the fat that you can see that I am marking out. And this is a bleeding from, the angiomyolipoma. It's massive retroperitoneal hemorrhage. If retroperitoneal hemorrhage in angiomyolipoma, is it more common in males? Is it more common in females?
Females, sir. Female.
Yes. Is there any triad that you know inside an angiomyolipoma or a bleeding angiolipoma? Is there any triad? So I'll tell you, there is an interesting triad which is known as the Lenks triad. LENKS. Many examiners, we are fond of asking about the Lenks triad. Again, it's the same thing. You can have flank pain. There is going to be ecchymosis and discoloration and pain inside the flank, and there is going to be a retroperitoneal hematoma. So this is known as the Lenks triad, and this is also commonly asked. But the thing that I wanted to tell was that once if you are fixated on trauma, don't miss upon the obvious things, especially if you have pointers over here. You can see the whole fat. So I think that this is important that you have to read the CT scan in total, right, Aditya? But you're doing very well.
Sir, in this, suppose if the white arrow which sir, can it be, okay, it is angiomyolipoma, sir, but suppose if it was urine plus blood, suppose. So if I am suspecting a grade 4 injury, as in it is extending into the pelvic ileal system, so can this white arrow be black urine, or it cannot be like that?
No, Aditya, first of all, urine will never form in the form of these grapes, Urine, mother, once it collects, then it takes the shape of, the perinephric, area. And secondly, if you remember a urinoma, then what will happen is that it will be absolutely cleared. It won't be, having all these, if we can call this, irregularities which are there. Fat, in angiomyolipoma, it can be mature fat, it can be immature fat, it can be interdispersed. So this is definitely not urine. And then the Hounsfield unit, the most important thing is that you're going to see the Hounsfield units. The Hounsfield units of a fat is always going to be very negative. It's going to be minus 15, minus 20, and urinoma is not going to be that much, right? It is going to be in some positive. So that's why it is not urine. Urine will never take this form. If I have a CT scan of urinoma, maybe I'm going to put it up, right?
Okay.
So this is after trauma. The patient was a known case of an exophatic angiomyolipoma Wunderlich.
Yes.
Now, Aditya, what is this? Is a sagittal cut. Can you comment about the sagittal cut? What is the grade of injury?
This appears to be a grade 4 injury, sir, because
Yes.
This is a, I think this is a delayed phase, and the urine.
Yes.
This is a urinoma. So the pelvic
Yes.
ileal system, the dye is extravasating out.
Yes. Yes, and as you can see, is that it is confined to the girotas. You can see that in a there has been a demarcation which is formed on account of the injury in between the urinoma and in between the psoas muscle. This is a sagittal cut again which has been taken, and these are those cases in which once you're given inside your exam, you'll always be asked about how you're going to manage this urinoma, whether you want to put in a DJ stent. How you're going to, how long you're going to keep the DJ stent, whether you want to drain it ultrasound guided, whether you want to put in ultrasound guided PCN inside the urinoma. So this is one of those cases which can take you inside that direction. But you are correct. This is a urinoma in which the urinoma is confined to the girotas fascia, right?
Yes.
This, Aditya. We just have 3 more CT scans. I wanted to, show you all varieties and all types of CT scans that you can get in trauma. So now we're just coming, maybe another 3 more CT scans. We'll show you all grades, all types. So what is this, Aditya?
So in this, only the left kidney is visualized.
Yes.
And there appears the left perinephric strandings are there, and it appears there's a large subcapsular collection.
Yes.
On the left side.
Yes.
So
you think that it is a grade 1 injury?
Based on this CT scan, yes, sir.
Okay, so now you have you can have some enhancement over here. Can you see the outline? It is enhancing. Also with the kidney parenchyma, is the enhancement of this structure similar to that of the enhancement of the cortex of the kidney? Is it same?
Yes, yes.
It seems to be same.
Okay, so
do you think that if...
Okay, is it an abscess?
What else can it be besides a subcapsular hematoma? What else can it be?
It can be an abscess, but is it?
So you're basically saying that it's an abscess. It's because you have enhancement of the periphery, and this is known as the ring sign or the rim sign. So you're thinking that it's rim sign?
Yes.
So Aditya, it is not an abscess. It was a cyst. We had this patient who had a large cortical cyst, and he had a trivial trauma. So now this is blood which has bled inside the renal cortical cyst. But the thing that I want to say is that inside the exam, if you are not given a history, then you will not be penalized for calling it as a renal abscess. This is because the outline of the cyst is enhancing. The most likely it is a grade 3 cyst, a Bosniak type 3 cyst. This is because it's irregular, it's thickening, it's enhancing. So at the same time, there is bleeding inside this Bosniak type 3 cyst. So you can keep the DD of an abscess, you can keep the DD of a subcapsular hematoma, you can keep the DD of even bleeding inside a cyst. Then you can see that there is some tethering also. This is on account of the trauma which is going outside the wall of the cyst. So nobody is going to penalize you inside the exam. You can keep a very healthy diagnosis. These 3 you can keep. And many times the 4th diagnosis that people keep lower down is a cystic RCC. Even though cystic RCC does not look like this typically, but on account of the enhancement of the wall, even though cystic RCC will be smaller than this, but however, very low down you can keep that also. But this is actually a case of a large cortical cyst in which the patient had trauma and he bled inside the cortical cyst.
Okay.
So Aditya, this is an angiography. Any comments about the angiography? The patient had a renal injury, and this after renal injury, he had hemorrhage, massive hemorrhage, and then a CT scan was done. A CT scan was done, showed a circular area of enhancement and pooling of contrast. So this is the angiography that was done.
Okay.
So what are your comments about this angiography? Are you happy with this angiography? Do you think that it's a good angiography?
Yes, sir.
Yes. So what do you find inside this angiography?
So there's a pseudoaneurysm on the superior aspect of the right side renal artery, or the right branch
So there's
of the
something
renal
which is
artery.
known as the right side renal. So there is something which is known as the right side renal artery. Can you be more specific? This angiography is very good. Can you be more specific?
The superior branch of the right, or as the right polar branch, superior polar branch of the right renal artery.
Okay, Aditya, can you see? Can you see the main renal artery?
Yes, sir.
So after the main renal artery, this is bifurcating into two. So what are the two branches of the main renal artery?
Okay, okay. Anterior and posterior.
So there's nothing like, you have to be very careful inside your nomenclature. This is because this is a very good high quality angiography that has been done. This is a pseudoaneurysm of the anterior artery, anterior renal artery. You can see the posterior renal artery going posteriorly and dividing, and there you have the anterior. So it is a large pseudoaneurysm. What could be the cause of this pseudoaneurysm, and how are you going to manage it?
The cause might be, sir, it can be post-traumatic.
Yes.
Then it can be post-PCNL also.
What are the most, Aditya, what are the most common causes of AV malformation or a pseudoaneurysm inside the kidney?
Iatrogenic, sir. Post-PCNL.
Okay. And so you think PCNL, do you think that PCNL causes more AV malformations, or do you think that FNACs cause more AV malformation? What is the most common leading cause?
I'll go with PCNL, sir.
No, see, the PCNL does not cause, even though it is one of the causes, it does not cause. Even FNAC would not cause. The thing that we wanted to hear was true cut biopsies. Sometimes true cut biopsies of the kidneys has to be taken by the, the nephrology people, they are taken. So this is exactly what has happened. The nephrologist has taken a true cut biopsy of the kidney. And as you can see that he has caused a major AV malformation inside the anterior renal artery and the main trunk of the anterior renal artery, and the patient had got massive retroperitoneal hemorrhage. He collapsed on the table. And how are you going to manage this patient? See, the thing that I wanted to tell you was that inside the PCNL, usually the AV malformations, they are more inside the parenchyma, they are more inside the cortex. But as you can see, that this is, I don't, not to criticize them, but they have actually gone through and through, and this is very medial, superior part of the kidney, and they have taken even maybe gone out of the kidney, and this has caused this AV malformation. So how do you want to manage this AV malformation, Aditya?
So, the patient came with hematuria, so I'll do the angio. This is the posterior branch. This is the anterior branch.
Yes, this is the anterior branch we were just discussing. How are you going to manage?
So I'll do angioembolization.
Angioembolization with what? Yes, you have to do a selective angioembolization. It is going to be an easier angioembolization because the intervention radiologist who has given this kind of an angiography will be able to do it. And what are you going to do the angioembolization with? What materials do you have?
So we have this gel foam, then coils are there.
What is better, gel foam or coil? Which is better? So coils are much better, Aditya, but the only problem is that they are very expensive. This is a very large AV malformation. It can be done with coiling, but however, I think that around 10 to 12 coils would be required inside this. So it's going to cost the patient very highly. So gel foam is a temporary, sometimes, revascularization occurs with gel foam. Gel foam is very cheap, easily available, but however, sometimes in such a large aneurysm, maybe gel foam is not going to work. So that's why you have to use steel and metallic coils. Are we okay, Aditya?
Yes, sir. Sir.
So I think that I've been able to discuss everything about the CT scan, all the grade of injuries, all the type of injuries, bilateral injuries, cases, angiographies, AV malformation, pelvic injuries. I think that I'm going to over-exceed my time, but I think that if Dr. Sood and Dr. Chabra sir sometimes give me another opportunity to sit with the residents, and it would be, even though I have just maybe covered around 20% of my presentation, but I think that it's already 9:20, so we can do it some other time if Dr. Sood and Dr. Chavda allow.
It's okay, Nachiket. No issues, no issues. So we can cover the lower tract in the next, I think, classes. Okay.
Sir, actually,
I'll just,
sorry, sir.
Nachiket, are you done with
Sorry,
it?
sir.
Or,
No, sir. I have a lot of. But the thing was that I wanted to go really slow on renal trauma. This is because I think that this is one thing that they always get inside their examinations. And genito-urinary trauma was too big a topic. So if the council later on will allow me to finish it some other time, this is because I wanted to make sure that the boys, see all varieties of trauma. So I've been very slow. And I think that I've exceeded my time also. But I actually wanted to make sure that they do this thing properly, sir.
Now, Nachiket, I'll just look at the chat. If any question is there, I think you have covered almost all the areas of, especially the renal trauma. But what I see in the chat is one question from Neeraj, which I think you have answered. When to suspect renal artery thrombosis in renal trauma?
Yeah. Yes, sir. I think that we discussed that inside the slide. Maybe we've already. I mean, the features of a renal artery, injury. They are actually, the CT scan are very classical, and it cannot be missed. And if the opposite kidney is normal, then clinically it would be very difficult to identify that the renal artery has got thrombosed. So the renal artery thrombosis, if the patient does not have a history of hypertension and suddenly he develops, malignant hypertension, and with this kind of a picture on CT scan, then I think that the diagnosis would become obvious, sir, but it requires a clinico-pathological correlation, a clinico-radiological correlation to make the diagnosis.
Let me have a look of this chat section, and anything else is there. Yeah. Can paranephric collection can cause page kidney? This question from Surjit Singh.
Sir, paranephric collections can cause page kidney. Actually, maybe inside the next time when I'm, if the opportunity is given, page kidney is always asked. Surjit Singh, page kidney is always asked inside the exam. If you're doing very well as far as the CT scan reading is gone, and if you have done the diagnosis and management, then always an examiner will ask about the page kidney. So the page kidney term, it was given by Irving Page. And Irving Page gave this term inside 1939, and he did an experimental model inside dogs in which he wrapped the kidney with cellophane, and he found that this cellophane, it induced an inflammatory reaction, and this caused page kidney. So yes, definitely, ultimately, even if the hematoma is paranephric, it's not as if it doesn't cause compression. So I think that any kind of a collection, be it paranephric, perinephric, or capsular, can result in page kidney. Then you also have to think is how much is a paranephric area. It is a very small area. I mean, it's very difficult. Even on the table, sometimes it becomes difficult to identify the capsule, where the perinephric area is, where the perineal fat is. Also, they just become, one type of cemented, structure. So I think that paranephric collections can result in page kidney, yes. But it is one thing that you are always going to be asked inside the exam.
Another question is, what will be the manifestation if renal artery and renal vein thrombosis coexist?
I think that it's, I've not seen a case in which they are coexisting together. But if the renal artery and renal vein, both of them, they are coexisting together, then I think that the patient is going to have a mixed, feature of a renal artery and a renal vein thrombosis, and the outlook would be very grim. The patient would have hematuria, the patient would have hypertension, the patient would have even proteinuria, massive proteinuria, so that you're going to have a mixed picture. And the only difference that I can think is that maybe inside a renal artery thrombosis and renal vein thrombosis, you would not have those features of maybe, the enlargement of the size or some perinephric collection, like fluid collection of the sweat sign that we get. But I think that the question that has been put is a very arbitrary question, and you just have to combine the symptoms together.
Okay. Thank you, Nachiket. That was from the chat section.
Yes,
I think you have very nicely covered the whole contour and the whole spectrum of renal trauma with the different type of contrast images, right from the contusion to the lacerations to venous thrombosis to perinephric hematoma to the angiomyolipoma rupture and with the perinephric bleed. I think all residents would have gained. I'll just place on record the guts of Aditya. He has single-handedly taken the shower of questions from you and has been successful, I think, in managing all the CT.
Yes,
that
sir.
was very commendable. That is very commendable.
Yes, sir. He's a good boy, sir. He's a good boy.
Yeah, he volunteered and he did very well because the frames were single frame and sometimes you take some time to think and all that. But he was
Absolutely, sir.
spontaneous and he was almost right in most of the occasions. Yeah.
Sir, if he would have been giving the exam, then all of us would have passed him, sir.
Okay, thank you, Nachiket. Over to you, Dr. Rajiv and Dr. Rajiv.
Thank you, Nachiket. It was an excellent coverage, really covered well. I really agree with you that the time was too short for a genito-urinary trauma because it is an extensive thing, multiple sites of injury. Let me see that whether I can incorporate you for the remaining part. Some other day I will let you know once, because there are other parts also, ureteric injury and other genito-urinary trauma which has to be covered and it comes into clinical practice.
Yes,
but
sir.
Whatever you have done, an excellent thing discussing the renal trauma, the various types, how it can be managed very well, and there's a good interaction from the resident side also. I really appreciate the resident. The resident was well prepared with all the bombardment which you can give.
Yes. I think that even you would have passed him with flying colors.
Definitely. So I, on behalf of USI and ISU, thank you very much for sparing your valuable time and being a part of this program. We will really be even troubling you in the days to come to helping us in making this program a grand success. With these few words, I would like to request Professor Rajiv Sood and Professor Arun Chawla to say a few words as a conclusion to this program. Over to
you. Thank you, Dr. Rajiv. Everything has been said, and Professor Nachiket has done a wonderful job, and he deserves another slot, definitely. And this kind of discussion is very, very important for all the residents, even for us. So it is refreshing everything, all what has been the beautiful collection of X-rays, imaging, and also the interaction which was done by Dr. Aditya. I congratulate Dr. Aditya, especially you, as has already been told, and I hope that similar zeal will be shown and expressed, the desire will be expressed by more and more residents, and it will become more and more interactive in the time to come. That's all. Thank you very much again. This was wonderfully covered.
Thank you. Over to Arun. Arun.
No, sir. I think everything has been said. I just want to bring attention to one point for the residents. They would have seen the passion of Dr. Nachiket in teaching. Not many people will be knowing he's a very good teacher, and he is very popular in North as the PGs will throng him just for listening to him and learn from him. So you can see the type of correction he has got. Worked hard on getting all these CTs put in line, covering right from simple contusion to right to the angiography showing aneurysm. It shows efforts and his passion and dedication. That was commendable. That's what I have to say. Thank you, Nachiket. Thank you. You made the day
very much, sir. Thank you, everyone.
Yeah.
Thank you, Dr. Sood.
And once more, I thank once again Nachiket for the wonderful deliberation. Now, on behalf of USI ISU, I would like to thank Navneet and Kiran for the support they are giving to this program. Thanks on behalf of USI ASU. And again, I thank on behalf of USI ASU, the Formica division of Lupin, who has come forward to support the Urological Society of India in this endeavor of USI Resident Smart Learning Program. Thank you, Formica division of Lupin. Thank you all once again.
Thank you. Bye-bye. Thank you, sir. Good night. Good night.
Thank you.
Good night.
Thank you very much. Thank you.
Good night, sir.